So we're live. How is the sound? It's good? Ready? Okay, fine. So, good evening, my friends. Good evening from Kiev, Ukraine, the country that are in quarantine, that as many of your countries, unfortunately, and we have to stay home without work, without dentistry, without our passion. And this is our actually initiative to support all our colleagues all over the world with this live streaming and also some online masterclasses that we open for free. I hope this time that you stay, unfortunately, in quarantine, you can spend in a more efficient way to study, to learn, to rest at the end of the day, to keep power for upcoming dental, let's say, fights or dental battles with caries and with aesthetics and with patients and whatever. This time we will do a live broadcast in English because a few days ago it was in Russian language. So for our Russian-speaking friends here, sorry, we will do just in English. And this live broadcast actually is dedicated to questions and answers related to dentistry. So any questions you have, feel free to ask. It's not just a topic of aesthetics or endodontic treatments or whatever, just any questions you want. You can write down in this chat, I will read it, and I will reply to these questions within 1 hour. Okay, so before we will answer your questions, I would like to mention that we do this Dental Talks program on our YouTube channel frequently. And last time we did it before Christmas time, and actually during this live Q&A and Dental Talks program, we defined winners of our contest that was held in BG Dental Cases episodes that we are running in our YouTube channel. So last time, in episode number 11, BG Dental Cases, there was a question about endodontic treatment and preparation of pulp chamber before adhesive dentistry. Let's say there was a question, how do we prepare pulp chamber for bonding procedures, let's say, or for adhesive core build-up procedure? And we got a lot of replies, and we promised that the winner of this contest will win from our side participation in online masterclass about occlusal anatomy and bonding procedures for free. But during this quarantine, we decided to give this online masterclass for free for everyone. So basically, all of you guys that replied to our dental episode number 11 will get our notification from administration, and you'll get free access to this online masterclass if you didn't participate in online masterclass before. And thank you very much for participation. Actually, I would like to highlight and I would like to give an answer for that question from my side, and then we will continue with your questions, guys. So the question was, how do we prepare pulp chamber for bonding procedures? Okay, and the answer is pretty simple. I will give exact sequence that we follow in our clinic. So once I finish endodontic treatment, I do sandblasting with aluminum oxide, 23-27 microns, actually what I'm using. I use device with water, okay, it's Rondoflex from Cavo. We do sandblasting, we rinse, we dry, and then we go for simple adhesive protocol. But one more tip, before doing sandblasting, once I finish my obturation, I do one thing. I take hot plugger and I slightly desobturate gutta percha from orifice side for about 1 millimeter. So I go with a hot plugger inside the root canal for 1 millimeter. In that way, the sealer will evaporate from around, and I will compact the gutta percha more precisely. This way will give me possibility to go for adhesive dentistry in easy way without any risk that acid gel will penetrate between root canal and gutta percha, and I will have some compliance later on. So basically, hot plugger 1 millimeter, packing again, then sandblasting with aluminum oxide, and then we go for adhesive protocol. If we use total etch adhesive system, we etch dentin for 5-10 seconds, rinse, dry, and then we go with our adhesive system. So that is the simple procedure, but the tip just to go again with a hot plagger to give better conditions for etching procedures and evaporation of sealer. Okay? So we continue. By the way, I forgot to ask you, I started everything, but I forgot to ask if sound is okay. Okay? Just put plus if the sound is okay. Okay? This is important for me just to be able to interact efficiently. And also I would like to ask you one more thing. I would like to see where are you from? Actually, write down please which country are you from. It's interesting because we have a really big, I would like to say a huge international audience, and I would like to see which countries now are following this live broadcast. Let's go for Q&A. We made a quote on our Instagram account, and we got some replies from, so actually not replies, we got some questions from Instagram. So I will start replying questions from Instagram, and then I will reply your questions here in this chat. Okay, so the question was, tips and tricks in dental photography. There was a question. Actually, it's not a question, it was just a request to give us some tips and tricks in dental photography. It's actually a big topic, and it's difficult just to reply to that request during live Q&A session without showing you equipment, without showing you settings or whatever. So I would like just to mention that dental photography is a pretty simple procedure. We just actually play with 2 or 3 settings for doing portrait pictures and do intraoral pictures. Okay, the quality of your pictures comes from light source. Okay, that is very important to have really good light source. So I would recommend you, if you are going to buy something in terms of dental photography equipment, is to buy really good and high quality flash. My personal preference is to have twin flash. Okay, and I would like, actually I'm buying the brand products. For example, if I use Nikon camera, Nikon lens, I buy Nikon twin flash as well, R1, C1. If I'm like a Canon user, for example, I buy flash from Canon. I like to work with twin flash. And then another thing that is also super important in dental photography is to have good lens. Also, don't try to save your time buying cheap lens. Buy really good brand lens. You can save some money in order to buy not expensive camera, not expensive body, but later on, after, maybe you will earn more money in a few months, maybe a half a year, doesn't matter. You can upgrade your camera, but you will still use your twin flash and lens with a new camera. Okay. Also, regarding dental photography, you can actually go to our Instagram account and scroll the timeline and check settings, because maybe a few months ago we actually uploaded settings for cameras for portrait pictures, and also settings for the camera that we use for intraoral pictures. If you will follow these settings, most of your dental pictures will be pretty fine. So basically it's as I mentioned, it is pretty simple. I mean, dental photography is pretty simple. Okay, let's reply one of the questions from the YouTube here. I use Optrogate for front side mirrors, but it's very difficult sometimes. Okay, do you have any advice on how can I make my life easier? So the question, this is the question. I have recently started preparing teeth with dental operative microscope. Perfect, congratulations. I use Optrogate and front side mirrors, but it's very difficult sometimes. Okay, yeah, it is difficult, especially when you work on posterior teeth. Actually, when you work on posterior teeth, it is difficult either you work with microscope or without microscope, because it's difficult to access posterior teeth. So do you have any advice on how can I make my life easier? Actually, again, it's not a defined question. How can you make your life easier? Train yourself on Phantom. Train yourself in simple procedures. If you would like to enter microscope dentistry in more smooth sequence, let's say, or in more smoother way, you know what you can do. You can actually do some simple dental hygiene procedures with microscopes, by the way, just to accelerate passing of the learning curve. This is advice, okay? And with microscope, if you started to work with microscope and you want to continue to work with microscope stress-free, don't take big cases from the very beginning. Just take some single unit case, for example, or you do endo, or you finish your endo and you do crown preparation, just single tooth. Just don't force yourself. This is simple advice for every single practitioner, for every single dentist that start to use something new. For example, you start to use microscope, now it's a new environment for you. Somebody maybe started to do implants, and this is new environment for them. Somebody started to do just veneers, and it's not a new environment for you. So the advice is pretty simple. Don't take big cases and give yourself more time. For example, if previously, before doing any dentistry without microscope, it took you for about, let's say, 1 hour to do a preparation. Now take 1 hour and a half, just not to put yourself in stress. This is my advice. Okay, good. What changes in dentistry do you expect after Corona? Wow, that is an interesting question, by the way. That is interesting question, by the way, and it's a pretty deep question. What I would say, definitely, patients will be more keen, let's say, in prophylaxis, and they will be more keen into disinfection and sterilization. So now, one of the marketing tools from some dental offices will be highlighting that the level of sterilization and disinfection in clinic is really high. And I can expect that the prices for all this equipment, the advanced equipment, autoclaves, the new generation of the autoclaves and so on, will be a little bit growing up, because it will be a standard to have it in the dental clinic, and there will be standards for timing to disinfect instruments and also to prepare dental room between patients. So the time will be extended. And one more thing, maybe we will decrease the total number of patients per day in general dentistry, let's say, but in this case we will increase time for each patient, which will include disinfection procedures, which will include more hygienic procedures like rubber dam utilization, like more single-used instruments, okay, and to do dentistry in non-stress and non-rush way. So basically, procedures will be extended in time. This is what I expect. And the prices at the beginning, after Corona, will go down, because during the quarantine, many people are not working, and they do not have enough income to maintain their current life. So they are now in non-comfort zone with money that are going down. So basically, the prices for dentistry are straight after Coronas maybe will go down, and there will be less aesthetic cases after Corona if economy of the country will be affected. But I'm optimistic guy, and I would like to say that all this issue around Corona will end. Maybe soon. I really hope that it will end soon, and it will keep us like a half a year, just to reapproach ourselves and to adapt ourselves to these conditions, and then our life will go with a normal way. Okay, another question is, I would like to ask, do you use composite onlays and overlays, and when do you prefer them over ceramic ones? Also, in cases of full mouth rehabilitation, do you use night guard and from what material? Okay, good question. Actually, composite material is pretty good for direct restorations, and I use it for direct restorations. Regarding indirect restorations like onlays and overlays, if the teeth is vital, the tooth is vital, okay, occlusion is okay. It's not a bruxist, it is not parafunction, there is no parafunction, there is no clenching. It's just a caries defect that needs to be treated in cusp reduction and cusp coverage way. In this case, you can use composite overlays. But if I treat endodontically treated teeth, I prefer ceramic, because ceramic is more rigid material than a composite, and module of elasticity of ceramic is higher, which will absorb partially occlusal stress and will not transform and transfer occlusal force internally as much as composite material does. So basically, ceramic material in this case is better. Also, it is better in case when you have cracks, like MOD crack line, for example. And for full mouth rehab cases, I do prefer also ceramic materials versus composite materials. When I do full mouth rehabilitation cases, we give to our patient splint just like a few, just for a few months for the adaptation. We are using the hard material, pretty similar to the one that we use for bleaching, for example, with a thin thermoplastic material. It's 1 millimeter thick night guard material, just for 1 or 2 months, just to keep muscles of our patient adapted to the new vertical dimension, to the new occlusion, and then you don't need the splint because the system will work as it is. Okay, perfect. Very nice. Okay. This is the question. Hello, FRC. I don't know what is this. Fuse zircon versus metal. It's a fiber post. Okay, fiber post, I think, right? FRC, fiber reinforced core or whatever. I don't know what is this. If it is fiber post versus metal post, when do you use FRC post and core, and when cast alloy post? Czech Republic is here. Actually, is, if I understood your question correctly, so we have metal post or metal post and core, okay, that is customized, and we have fiber post and core that is also customized but it is chair side. I prefer fiber post and core versus metal post and core because I can do it in chair side very quickly, and it's more conservative, let's say. Metal post and core I would use in some cases when I have patient with resorcinol treated teeth. So basically there are teeth that you cannot bond to their structures properly because of the resorcinol. In that case, metal post will work better because it gives you more mechanical retention. That is the question. But I still prefer to do post-free dentistry, let's say. My personal preference, fiber post, I like more than metal post. But again, I'm more into dentistry with no posts. I have some problems with impression trays and I want to advise me. This is a really difficult question to answer. What kind of problems do you have with the impression trays? What type of impression trays do you use? Customized, or it is fabricated, perforated, metal, etc. So just few things. Personally, I prefer to use metal trays, rigid trays, okay, metal rigid trays, and adhesive for silicone material. This is what I really prefer. And I try in trays in the patient's mouth just to get a good fit of the tray, and then I do an impression. Good. Tips for preventing fogging of dental photography mirror. Good question. Few tips. First, you can keep mirror in hot water before doing photography. Okay, this is the tip number one. But there is a more simple tip. When I put intraoral mirror for taking photography, my assistant takes suction. Okay, just to the side. So the suction will be not interfering with mirror, and it will be not visible in the picture, but it will be active, and by that process there will be no fog on your dental mirror. If there is a little bit of the fog before taking picture, I ask my patient to breathe with mouth, just to take the breathe with mouth inside and to keep it. Assistant holds the suction all the time, and then I take the picture. Or again, you can keep your dental mirror in hot water before. Okay, good. How do you treat alveolitis? I don't do extractions, so surgeon treats, not me. Another question. Can you suggest where to buy microscope accessories such as video adapter, camera adapter? I have Zeiss Pro Ergo. Okay, so if you want to buy original parts, you just contact your local dealer. If you want to buy some material devices that are compatible with your Zeiss microscope, I can say that Zumax accessories are compatible with Zeiss microscope. So in this case, you just contact Zumax dealer and you buy the video camera adapter or mobile phone adapter that is completely compatible with Zeiss. I have Zumax and I also have Zeiss microscope, and I have my mobile phone adapter that I use from Zumax in my Zeiss microscope, and it fits perfectly well. Good. Another question. If you have molar with a small fissure, 2-3 millimeters subgingival, but no probing, what's your prosthetic solution? Crown to circle and reinforce the tooth or overlay? If I understood your question correctly, so we have subgingival defect, correct? 2-3 millimeters subgingival defect. Okay, good. So what is the sequence in that case if we have that subgingival defects? So let me reply. Actually, it was a question also from the Instagram, as far as I remember, about deep marginal elevation and strategies of restorative treatments in cases when you have subgingival defects. So I will reply to your question and also to this question from the Instagram together in a full way. So basically we have at least 3 different types of defects, subgingival defects, let's say. The first, easy case, when you have subgingival defect that is in sulcus and periphery of the defect is made of enamel, let's say in that case. So for that type of cases, we just do gingivectomy, we do isolation, then we prep, and we localize our finish line in enamel. So we don't do any deep marginal elevation, okay? This is first option. The option number 2, the defect is slightly deeper, maybe 2 millimeters, maybe 3 millimeters. So basically it's deeper than sulcus. It is not surrounded by enamel. Now you are in cementium and in dentin as well, but the level of the defect is slightly above the bone level, okay? In this case, you can do gingivectomy, then you do isolation, and in this case you can do deep marginal elevation. For deep marginal elevation, what is crucial is to have really good fit of your matrix. So you put your matrix. By the way, you have to have different types of matrices. You have to have different systems of matrices, because there is no one universal matrix system that works perfectly with everything. So basically you have to have different brands, different types, and whatever. So you have to get your matrix. Sometimes we pack with Teflon, sometimes it's just with a wedge, sometimes with a flowable composite or whatever. So that fit of the matrix has to be super perfect. And then we build up this subgingival defect with composite. So basically you have to have different transforming subgingival defect into, let's say, gum level defect or slightly to supragingival defect. The minimum amount of composite, the minimum height of the composite, and also the minimum width of the composite and minimum thickness has to be 1.5 millimeters or more, okay, not less. What type of composite you can use? In this case, you can use highly filled flowable composite, or you can use normal packable composite that you are building up this defect. So in such a case, when you lift up the defect with composite, your finish line, or the margin, let's say, for ceramic or composite indirect restoration will be localized in that composite. So that is deep marginal elevation procedure. And option number 3, or situation number 3, when you have defect which is pretty deep and it's at the bone level or even slightly below the bone level, in such a cases you have, let's say, at least 4 different options. The option number 1 is just to prep as far as you can and to localize your finish line in the intact sound to structure, but you may face afterwards with recession, with pocket, with periodontal problem, or something will be okay. Option number 2, in this case, you can do crown lengthening, okay. Option number 3, you can do orthodontic extrusion. Option number 4, you can do extraction and implant. So that is options that you may follow with such difficult cases. What is your favorite material to build up and why? Basically, if we are talking about build up after endodontic treatment, okay? Maybe if you mean that. So basically, there is no favorite material. It depends on the size of the defect. If defect is pretty big, I will use dual core build-up materials. For example, Core X Flow from Dentsply, or the one from GC. Actually, I don't remember exactly the name of the product, but it is exactly GC dual core build-up material, which is also nice. The consistency is nice, and preparation, the feeling when you prep it with burr is nice. It's hard enough. So there are 2 materials that I use for build-ups. If the defect is moderate or small, I'm using bulk fill materials for that. Light curable bulk fill materials like bulk fill flow from 3M, or bulk fill packable from 3M. This is just my opinion. Okay, good, very nice. Work under microscope, okay. Do we open the contact areas in crowded? Okay, so this is an interesting question. Do we open the contact areas in crowded lower anterior teeth while we prepare for veneers in order to get better alignment of the veneers? Interesting question. It depends on the type of crowding, and actually depends on the type of crowding and position of teeth. But in most of the times when we have crowding, okay, we are facing with playing with spaces. So we have to reorganize the anterior arch, aesthetic arch, to give equal space for adjacent teeth, okay, for central incisors, certain space, for lateral incisor, certain space, for canines, and so on. So in some cases we have to open interproximal areas just to play with spacing, with spaces. In some cases we just remove the extended part of the tooth in case if the rotation is really nothing, it's just low rotation. In this case we just remove extended part of the tooth, it becomes straight, and then we prep it for example, type 1 or type 2 veneer design. So that is the question. Okay, when do you post removing? When you do post removing with ultrasound, how much power do you use? When we remove post from the root canal with ultrasound, I use medium power to full power. with water, okay? 20, 30 seconds, not more. Then we do some rest and then we go, okay? But what is important, you have to remove some material around the post, so your ultrasonic tip will go more, how to say, efficiently towards metal. Because if you have a lot of composite around and you will try to remove the post with ultrasound, a lot of ultrasonic energy will be transferred into composite and efficiency will be really low. Okay, what do you think of the scope brands out there? How do you compare Zumax, CJ Optic, size? Any recommendation? Ooh, it's like, you know, comparing cars. It's like you are comparing cars. So size, if you have enough money, size for me is number one in terms of quality, brand, and feeling that you are size user, if you understand what I mean. Okay, it's a special feeling that you can afford to work with high level expensive equipment, and also you can promote, you can advertise this equipment for your patients. Okay, this is one story. If you don't have, let's say, a lot of money, let us be clear, but you want to buy a really good quality, really good ergonomics, really good support in terms of service, in terms of adapters, spare parts, and so on, I will go for Zumax, especially for the new model that is OMS 2380. This is the microscope, really good ergonomics, to be honest. One of the best ergonomics I have ever tried. So basically I have two microscopes, size and Zumax to 2380, which is really, really, really good. Okay, good. Wow, Ahmed, my friend, too many questions. What is ferrule? Not ferrule, ferrule effect. Okay, my friend, what is ferrule effect? So ferrule, Google it, my friends. You ask me a simple question that you can just Google. But since you ask it here, and I promise that I will reply, I will. So ferrule is the part of the tooth that is above the gum. Okay, so there is some sort of tooth that is above the gum. In ferrule, we have at least two parameters that we have to take into consideration. First is the height of the ferrule. The minimum, we are talking about classics. The minimum height of the ferrule is 1.5 millimeters. If it is less, we have to go for crown lengthening or for orthodontic extrusion or for extraction. Okay, and also we have thickness of the ferrule, the thickness of the wall. The ferrule, actually the tooth, the walls of the tooth. So basically we have to have enough thickness. So the minimum thickness of the ferrule is 1 millimeter. Okay, nice. So let's go. For bonding veneers, which tech more better, to use floss ties or brinker clamps on the tooth? Basically for isolation, when you do veneer or crown or inlay bonding, doesn't matter. I try first to use floss ties. Why? Because when I use floss ties, for example, I have space around the tooth. So there is no clamp with arch that can be on my way when I'm using brush or floss or scalpel blade or whatever. But we cannot use floss ties in all our cases. Sometimes we have to go for clamps because, for example, the preparation was low or the tooth doesn't have bulbosity to keep your floss ties on. So again, if I can, I go for floss ties. If no, I go straight to the clamp. Tip, in order not to waste your time. If you see that tooth is plain, I mean it's flat, no bulbosity, straight go to clamp. Floss tie will not work in that case. Good. Which prosthetic work do you propose in case of periodontopathy, solo crowns or bridge? When we have periodontal case, when you do bridge, it's not a good idea for periodontal case. In this case, we have to compare single units with splinted crowns, okay? With splinted crowns. So basically, splinted crowns may be used in case of periodontal case when you stabilized the procedure, but the bone loss was significant. In this case, you can use splinted crowns to spread all the forces into the block. Okay, this is advice. Okay. We missed you a lot. Why don't you post as many cases in English? You are not, it's not truth. For example, in Instagram, I always have first English and then Russian. In YouTube, we have playlists in English and we have same numbers of Russian. But I can tell you more. We do more English-speaking cases than Russian-speaking cases. So it's not truth. But I remember you, by the way, from Dubai. Dental photomaster for photography course. I replied this question. Do you use rubber dam for every case of the is some cases where it is not possible? Actually, a good question. I tried to use rubber dam in most of my cases, but sometimes it's not possible. In which case it is not possible? For example, when you have patient with old crowns, PFM crowns or whatever, and previous dentist prepped very, 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 very deep. And in this case, you have a special patient that doesn't want to do crown lengthening, for example, or orthodontic extrusion, and you have to redesign periodontium with your provisional restorations. I showed you one case. Maybe I will do a case review. By the way, it's a good idea to do a case review in our BG dental cases. But anyways, I had the case when I kept my patients with a provisional restorations for at least, I don't remember exactly the term, but it was about 2 months with several sets of provisional restorations, and finally we got a really nice architecture of gum. But the margins were very deep. In such cases, we can still do isolation, but gum will be smashed. In this case, I'll go for simplified adhesive protocol without rubber dam. So basically, for these cases, for crowns, this is important because for the crowns we have macro-mechanical retention. Okay, so it's enough to stabilize the restoration. So basically, for the crowns, in such cases, I can do simple cementation process. In such a case, I use self-etch, self-bond resin cement, for example, from 3M U200 in this case. For the rest of the cases, for veneers, for overlays, for inlays or whatever, I prefer to use rubber dam. Okay, good. What do you think about indirect flowable technique? What do you think about indirect flowable technique? Well, I don't know what is indirect flowable technique. I know what is direct flowable technique, when you put silicone index and you inject the silicone index with flowable material, if you mean that. So it's nice technique, it's nice looking, seems to be pretty fast, but I'm not using it for my cases. Actually, I do more ceramic veneers than flowable technique. Okay. Okay, let's go. Next, do you recommend vertical preparation? Do you recommend vertical preparation? To be honest with you, I have no experience with vertical preparations. All of my preparations have some margins, okay? Even I have some really cases when I do a 0.1 finish line, which is almost like a vertical preparation, but I don't have experience like the guys from other, let's say, groups showing in their presentations on so on. But I can say it works for some people, it works. So I'm not against vertical preparation. I'm a really good supporter of any approach that gives good result. This is the thing. Okay, tips for separated instrument removal. Microscope, morphology knowledge, banded ultrasonic tips. This is the thing. Good. I love your way in explaining any topics in dentistry. Thank you very much, Ahmed. Very good. Why you don't do live on Instagram anymore? Rania and other people, I would like to ask you now. What do you think nowadays about all these big numbers of live streams on Instagram? Personally, I start to feel all this situation with all of these live streams slightly boring. That's why I feel inside myself that if I will do also live stream on Instagram, I will be one of these people who are boring you. Say if I'm correct or if I'm not correct. If you want me to continue live Instagram broadcasting, I will do, no problem with this. If not, I will continue it on a Facebook, on a YouTube. Another reason why we do this YouTube broadcast is that we can keep recording for live, okay, time. Another reason why we do now a broadcast on YouTube is that we have people from Instagram, we have subscribers from YouTube, and also we have some people following us from Facebook and from Google, for example. So the YouTube platform is more universal than Instagram, and more people can join us from LinkedIn, for example, whatever. Okay, good. What do you think? What do you think about hydraulic condensation BC sealer? This is a bioceramic sealer, and hydraulic condensation technique. It's pretty nice. Nowadays it becomes a trend, BC sealer with a good results actually. I'm not using a hydraulic condensation technique. If I would use BC sealer, I would use it with a single cone technique. This is my personal preference, let's say. Okay. What do you use? What do you think about using of Rabidam on patients with decreased saliva production or even hyrostoma? Is it possible? It is possible. It is possible. For that cases, you can put some water from time to time from your triplex to your patients. You just take out the Rabidam, put some little bit of the water just to keep mouth wet, and then you go. And also you can wet the gum with water also, so it's not a big problem. Very nice, very nice. What are your tips of removing broken file without having microscope? That's the provocative question. Okay, I will give you advice because I did some separated file removal before I got my microscope. So the rule number one that you have to know is that you can remove more efficiently, let's say, file that you can see. So basically, if you have your file in coronal part, not in apical part, but in coronal part or in middle part of the root canal, and you can see that, you can remove it with ultrasound. But if the file is pretty deep and you cannot see the file, it's dangerous to start removal without microscope because you may do irreversible damage for the root that may lead in the future to get vertical root fracture, for example, or maybe for perforation during process of removal. Okay, not correct. I love live on Instagram. Okay, good. You are correct with not broadcasting on Instagram. See? So now we have two opinions. Two for Instagram and against Instagram. 50-50, by the way, as you see. Okay, thanks for sharing experience. Thank you guys for joining us. Okay, good. Next, if you have to replace old crowns, let's go. If you have to replace old crowns and there is metal post under, and you don't want to risk to remove it, How do you mask the metal post for your future crown? Opacker, or how do you do it for good adhesion? Okay, this is a good question, by the way. There are some cases when we have a really long and thick and huge metal post, like a customized post and core, for example. And on X-ray, on CBCT, there is no problem in periodontium. So basically, endodontically, they are okay. And we just need to replace the crown. In such a case, from our experience, because there are many options, but for our experience, what I can say, we do zirconia crowns for that cases. With opaque zirconia, we got better results with color match. Okay, and in this case, we don't need a real adhesion, so we just do a normal process of cementation. This is our approach. Okay, good. YouTube is better. See, now we have another opinion. YouTube is better for broadcasting. In composite restoration, for how long you air dry the bonding for removing extensive bonding? Okay, so this is the question. And for how long you cure the bonding after the bonding and the composite? So basically, when you have your bonding applied on the tooth, I air dry it slightly until I would try to explain. So if you have a lot of bond, you dry and it spreads everywhere. It leaks everywhere. It's fluid too much. So I air dry until the tooth will be shine. So we see the bond. And when you dry, it has to be stable. Okay. It has to be there, but it has to be stable. It's in a simple way to explain. I don't know how much it takes. It depends. For light curing, I prefer. It depends on the lamp, by the way, that you're using. But I prefer just to overextend it light curing procedure. Like, for example, 30-40 seconds. I light cure my adhesive before doing layering procedures. Thank you for all your work that you do for dental education all over the world. Oksana, thank you very much. All of us will do the education, because if I would not have followers, I would not do education. Okay, so all of you, all of us, we are contributing. That's good. Where do you buy orange floss? This is one of the most frequently asked questions. Adele White. This is the name of the floss. It is Swiss, but the quality is not good, by the way. But just go there. Since you know the corona situation, I think you may have more time to make videos, and we love them, by the way. Ahmad. You know, this is one of the most tiny situation when somebody starts to judge time of another person. I don't have enough time to do videos because, except of work, I have my family, and maybe you know, or maybe you don't, I just got a baby. My baby is just 1 month, so all of my time that I have I spend with my baby, and I love my baby more than videos that I made. Don't be offended, but anyways, I'm doing videos, by the way, a lot, you see them. And dental cases, we will continue with BG dental cases here on the YouTube. Just take a look. Where can you find these BG dental cases? I will show you. When you go to our YouTube channel, you go to YouTube channel, can we ask our staff to show the screen? Саня, можешь screen показать? So you go to our YouTube channel, okay? Yes? Then go here, playlists. We click on the playlists, and here in English, look, BG dental cases, play all. And you'll be able to see all of these videos. They are free webinars in English, okay? And we recorded, by the way, we recorded I think 3 or 4 more. So basically they will be uploaded soon. So follow us, keep on following us. And one more thing, which is super cool, we are preparing a really cool online masterclass. Can you share the screen also? So when you will go to dentaleducation.com, veneers and discoloration, basically we will send you the link here. There will be advanced online masterclass about veneer preps and discoloration, when I will be sitting with a lot of cameras around me. Okay, you have early bird registration here. Here the low price. Okay, so basically there will be multiple cameras, and it will be the way to do a masterclass as you are here with me. It's like an over shoulder. And one more thing, because of this, I would like to say dirty word, but okay, with all of this bad quarantine we have now situation, we decided to support you more. We will give you second masterclass for free about aesthetic treatment and about digital smile design. So you get two masterclass instead of one. Let's continue with questions. Let us continue with questions. In case without rubber dam in composite restoration, how do you dry the cavity after etching and washing? I use rubber dam for composite restoration. For me, it is must. Okay, so I will not give you an answer. How can I dry and so on without rubber dam? Okay, biomimetic approach says that we should use only Emax, and zirconia has more strength than we need. So is it true? Also, they refuse usage of post completely. So is it right now? Look, all of approaches in operative dentistry that we have to admire that they are just one of the plenty options. Okay, all of these approaches and concepts are just one from many points of view. We have to take it. Okay, and then you have to decide which concept to follow, which one is more closer to you, which one is more closer to the style of your practice. According to the biomimetic approach, they are right. Ceramic is more closer to enamel. Zirconia is more harder, and I agree with that. And also, I do not like to work with zirconia, because the question that I asked to myself, why should I use material that is stronger than any structures in human body? To compensate what? But sometimes I have to use zirconia, unfortunately, in case when I have metal post, for example, or I have really dark or black tooth and I have to mask the color. In this case, zirconia in our dental lab, with our experience, work better than Emax. But for the rest of the cases, I'm a big fan of ceramic materials, Emax or lacy ceramic or what? Feldspathic. Good question. Good. Recently I have a patient with 200 kilos. Wow, he is a sumo fighter or what? I can't put rubber dam, and if I flat the dental chair, he can't breathe properly. Have you ever met case like that? It's a root canal treatment. It is so hard. Yeah, that is tough situation, really. I got once a patient, he was not 200 kilos, but he was really huge, hugest patient I have ever met in my life. But I was able to put rubber dam. He was not laying down, he was staying in that position. It was difficult for him to swallow saliva, so basically we worked with a suction under the rubber dam, in the rubber dam, under, and so on. And I was able to treat this patient. I treated him for 3 or 4 hours. It was like a nightmare for me. I was sweating all my time with such a patient, and I got a result putting rubber dam. In other case, with that big patients, when they open mouth, you cannot see their teeth because there is a huge tongue, the same fat as the patient, and cheeks like the hugest cheeks ever. When you put Rabidam, you are a happy person. By the way, one thing, what I would like to admire. Now we have 145 people watching us live, but we have only 46 likes here. The question is why? You don't like this live, or you're lazy to put the like? I want to ask you to put the like, because if you put like, this video will be broadcasted more for more people. More people will see that, and all of us will contribute in global dental education. So that is the thing. Okay. What are the advantages and disadvantages of single loop and double loop floss ligature with a Rabidam? So, single loop technique is more softer, is more gentle and delicate. It works good in case when you have gum level. Well, now we have 58 likes. Look, nice. More. We need more likes. So single loop is more delicate. It works good when you have gum level defect, and when you have the defect or finish line or whatever at the beginning of the sulcus. Okay, so I will go for a single loop technique in such cases. When you have the defect that is deeper than half of the sulcus, for example, I will try double loop technique, but double loop technique is more aggressive. It's way more painful for the patients as well, but it is more efficient. What do you think about CAD/CAM, and do you use it for your daily work? Yes, I really in CAD/CAM dentistry, especially my dental technician. He is expert in CAD/CAM, and most of our veneers that we do are made. All of our veneers are made in CAD/CAM. So basically, we scan and we mill. If you ask me regarding intraoral scanner, I'm not. How to say? I do not consider myself as expert in intraoral scanners. I'm on my way. I'm still passing my learning curve. So basically I do both scanning and also I take impressions still. But I'm learning fast. Soon, maybe, if I would be super satisfied with all of these results, I will be able to do all my dentistry completely in digital way. I hope so. With a new, especially with a new scanner from Sirona. I'm Sirona supporter. With this new Prime scan, I will be able maybe to do my dentistry with a complete digital workflow. Dr. Maxim, a question on two messages. Patient came to me with a fractured core with a fiber post in upper central and lateral incisors, fractured below 2 millimeter, below the 2 millimeter ferrule effect. How can I bond well to the remaining dentin and resin cement, and now I can insert a new fiber post? I don't understand completely the question, but if you have patient with the old fiber post and core, for example, and your patient got fracture, and this fracture is deep, you have to understand if you can isolate the tooth, if you can get to to the level of the fracture, to bond well, to control this margin well, maybe with gingivectomy, maybe with crown lengthening, maybe with orthodontic extrusion, then you go with a simple procedure, with a simple sequence. If not, maybe it is a good way to do its extraction and to put an implant. Okay. How do you mask amalgam when you do an AIPC max crown in frontal teeth? Unfortunately, in Ukraine, we don't have amalgam. In Ukraine, it's forbidden. So we don't have a lot of patients with amalgam. If we have amalgam, I remove amalgam and I put composite material. This is our approach. Do you sometimes use Gluma? This is the question about desensitizing. No, I don't. I don't use Gluma. I don't use any of this sensitizer. I do just regular classic bonding procedures with adhesive systems. Congrats on your baby. Thank you for spending time with us. Thanks, guys. I love you. That's why I'm spending time with you. Since I don't know you, but I already love you. By the way, we have to say this to each other, that we love each other, because now with this coronavirus, all the world is in a big depression. Hysteria, you know, bad news, people are afraid, bad emotions, and we cannot actually communicate in a normal way. So that's why we have to spread more positive feelings, and love is the most positive sense that ever was made in the earth. Okay? So virtual love for all of you, my friends. I cannot hug you, but my warm regards. Next, when should I place fiber post and when not in endo, molar treated? Okay, for molar teeth. I would look, everything that I'm saying right now is my personal point of view, my experience, and my responsibility. Okay, that is important. So I don't put fiber posts in molar teeth. That's it. That's it. For frontal teeth, I do. For example, when I have short tooth, like a central incisor, just short. Okay, in this case, I do post just to reinforce my core material. Then I do core, and then I do crown. Okay. What is your advice in dental students in clinical stage? Read books, textbooks, journals. Okay. Use your since if you don't have family, if you don't have kids, use your time efficiently to invest this time to yourself. Okay. So now is the time of investment. Having this knowledge, you are building metrics that will grow and will be supported by your clinical skills. Clinical skills are the things that you will gain within years. This is continuous process. But knowledge, theoretical knowledge, it is short investment, let's say. Skills is long investment. So you do knowledge, you got some confidence, you understand sequence, you understand workflows, and then you go with a clinical experience. Can you please show us composite layer techniques? I cannot show you composite layer techniques right now here because we do just Q&A, but you can go to our where is this link for I will show you the link. Okay, let's go to Facebook. Let's go to Facebook. I will show you the link again for this online. Actually, I have a better solution. Look, when we go to our webpage, en.belograd.com, ты показываешь сейчас? en.belograd.com, you go to online courses here, online courses, and here is direct posterior restoration and simplify layering technique is here. This is free of charge. It was paid. You had to pay for that masterclass, but now we give it for free. So you go, you subscribe, and you get your question answered. Okay. Thanks for all what you do for dental community. Your tips are useful during our daily treatments. I'm really happy that all of my knowledge and my tips are really useful for you. Really, I'm really happy. Thank you. Which do you prefer more? Reading books, articles, or attending courses to increase your knowledge? Thank you for this live. This is actually also a really good question. You know, you cannot actually divide them because the learning process is the combination of multiple actions: reading, attending courses, attending lectures, webinars, talking to your colleagues, sharing experience, and so on. But if you just go with a strict question, books or courses, let's put it like that, and I have to choose courses because I'm more lazy, you know, and sometimes I don't have enough time to read, but sometimes you need to have information in a really short time. So in this case, I take my agenda, I take my schedule, I see that, for example, in 2 or 3 months, or maybe next month, I will stay one day with a course, with a webinar, or I will go for somebody to learn, because this person, by the way, for all of you, for young students also, for young dentists also, the most fastest way to learn is not because I'm doing courses. This is axiom. The fastest way to learn is to attend course. The reason why is pretty simple. The teacher, the lecturer, the instructor spend his time to gain clinical experience, spend his time to read books, to read articles, to gain all this knowledge, to process all this knowledge, to pack this knowledge into sequence, to give you, to take it, and to use it. So this is the best way to learn. It is more expensive way to learn than books and your mistakes during the treatments of your patients. But this is the fastest and efficient way to learn. That's it. So if I would like to gain something new for me, for example, I will go to course. Definitely, this is the thing. For example, I'm attending now courses about occlusion. I read books before about occlusion, but before it's just a book, it's just a theory. When I do course, hands-on especially, it's easier for me to go with all this knowledge that I gained from books and from the courses. You can attend our hands-on courses, by the way. After all this quarantine, go to en.belograd.com, hands-on courses, the most efficient ever that you may attend. I can assure you, because they are unique, with full hands-on, 100%. Okay. How do you solve the problem of sensitive after composite? Proper bonding protocol. Proper bonding protocol and proper layering protocol. That is super important. In this case, you will have no post-operative sensitivity. Doctor, last question. Why last question? Are you running? I'm still here with you. Have you used the inverse injection composite layer technique? If you have, I don't. I heard about this inverse technique. I know what you mean, but I have no experience with that. No, I don't use Gluma. I don't use Gluma. Did you remove live video or stay? This video we keep on our YouTube. Do you use pulpectomy for children's teeth, and how do you do it? I don't treat kids. That's it. I refer them for pediatric dentists. They do pulp. How do you say? Pulpectomy. Pulptomy. They use pulptomy. They use pulptomy in pediatric dentistry. Let me reply some questions from the Instagram, because we have people that asked us questions, and we promised that we will reply these questions from the Instagram. What is your channel name? Okay, so this is not the knowledge appreciate. Also, how do you achieve the thin incisal edge in case of unlingually positioned interiors? Okay, good question, by the way. So the question from Instagram. Preparation of lower anterior crowded teeth. Lower anterior crowded teeth for veneer restoration. Shall we open the context? I answered that. Also, that question is interesting. How to achieve thin incisal edges in case of lingually positioned incisors, not wide platforms? Shall I increase incisal clearance? That is interesting question. So when you have lingually positioned teeth and you bring them by veneers forward, you may get these platforms, unfortunately. If you want to get rid of these platforms, you will have to prep slightly more. and then you move them forward, and then you may equilibrate something from the lingual side as well, but I don't think that is a good idea. It is not a good idea. Actually, it's a bit of compromise between getting this thick platform and maybe some phonetics problems, or to over prep teeth. So let's do summary. If we do mock-up and I see that the platform, the thickness is about 3 millimeters or more, I will go for orthodontic treatment before, with the liners, for example, with the liners, and then we will go for veneers in such a case. If it will be about 1-2 millimeters, it's okay. It's okay. So another question from Instagram: can we adjust lithium disilicate crowns after cementation? If yes, with what? We can. So basically, we can adjust lithium disilicate crown in patient mouth after cementation. We use fine diamond burrs, and then we use rubbers as our dental technician uses in dental lab to polish ceramic material. So full process. Coarse rubber, fine polishing rubber, and then paste. You have to do that, otherwise you may compromise antagonists because of the abrasive features of ceramic. Another question from the Instagram. I use brush and bond adhesive from Parkel of all of my posterior fillings. What do you think about that adhesive? Is there anything better? You ask me, guys, about certain material. I have no idea about this material. I have never tried that material. But what I would say, for people that are searching for some materials to buy something, for example, for young people, or maybe you are not satisfied with the results that you have and you are searching for something, for some replacement, what I can say, if you would like to get proved result, you have to take something from classic approach. For example, in adhesive dentistry, we have two classic adhesive systems. Fourth generation, which is total edge, primer separately, bonding separately. For example, OptiBond FL from Care, golden standard. Another one is from sixth generation. It is self-edge adhesive system, classic, when acid primer is separate and adhesive is separate. These two adhesive systems are classic, and they are researched for more than 20 years with a classic protocol. They work perfectly. So that is my advice. And that is my advice. Okay, that's good. Let's check questions from where? We have also questions from Facebook, right? We have questions on the Facebook platform, not only on YouTube, because we are broadcasting in the two platforms simultaneously. So basically, can I see these questions from the Facebook? Are you pro the mimetic approach? Yeah, we replied this question. Fantastic job, thank you. Also, by mimetic approach refuses. Yeah, actually, I answered the same questions like in the YouTube. Keep on going. Okay, what are the steps to determine the best occlusion? Okay, so that is the question. What are the steps to determine the best occlusion in endodontulous patients when doing full mouth implant restoration? Thank you for the live. I'm not expert in that question, to be honest, so I will not give you a reply. So sorry, I'm not an expert in the patients with no teeth for implant cases. But actually, logically, you can define the position of the lower jaw. You can use some the wax pellets, for example, to determine the CR, and then you transfer this CR into the guide to put implant. Then you do provisional restoration. Then you can recheck this CR, or if you are in another occlusal concept for when you follow, not CR, you go into the reference position, which is easier to define, reference position, and then you can go for full mouth implant rehabilitation in reference position. So it's like that, but this question is pretty difficult. Okay, good. So let's go also for one more question. One more question we have from where? Let's go back to YouTube. We have a lot of questions from the YouTube actually. So let's go. Okay. What are the limitations of pulp cupping? Is there any age limits? Interesting question about the age. As you know, as older we become, as less interactive our immune system and regenerative process as well. So basically there is a more higher risk to get some flare-up with actually it's a good question, because more frequently you may get flare-ups in young people because they have really high immune system. But what are the limitations? Let's say I cannot give you a certain answer about the age or whatever. I think there is no limitation according to the age. But when you prep, for example, caries, let's say, okay, which is interesting thing, when you prep caries, there is infected dentin, and there is a big probability that there is also the pulp response for the caries process. Okay, so when we open the pulp during preparation, and there is bleeding, and the color of the bleeding is dark red, and the bleeding is more than 1 minute, the lasting of the bleeding is 1 minute. In this case, I go for the endodontic treatment. If the bleeding is red and it stops within 1 minute, I can go for the pulp cupping, and then I go for my restorative procedures. Tell us, please, tips for making pictures of posterior teeth. Okay, for posterior teeth, if I'm not doing full arch picture, but I do a picture of certain teeth, like a quadrant, for example, I'm using partial. There is a special partial mirror. Maybe it's here. Let me check if I have it here. No, it's in another office. So it's like a long mirror. Then I ask my patient to put mouth as wide as possible, and then I just take a picture with my camera. There is no some super tips. Just open mouth wider and to use the long mirror, and that's it. And you have to have the good light source. That is important. Okay. Another one. We got the mirror, by the way. A cameraman works our stuff, give that type of mirrors. We use that type of mirrors, okay? A question is, what do you prefer, Emax or Impress? For posterior teeth, we prefer Emax monolithic restoration. For anterior teeth, we prefer Impress CAD multi. This is our question. Is using Emax bridge in posterior with heavy occlusion safe enough? That is difficult. Basically, Emax material is more. Emax material is not designed for bridge restorations. You can use bridge with Emax for lateral incisor, for example, but for posterior teeth, it's pretty compromised. So I would rather go for implant or zirconia bridge for in posterior areas. That is the question. How do you treat sensitivity that develops in vital teeth in which you have given cuspal coverage with Emax overlay on onlay? Okay, so we put our overlay and we got sensitivity. First of all, you have to do all your best not to have postoperative sensitivity. And there are some rules that you have to follow. First, IDS, immediate dentin sealing procedure, gives you a very super low number of postoperative sensitivity cases. Then you have to follow proper bonding protocol. Then your restoration has to have good fit, because if the internal fit of your restoration will be not okay and there will be pretty thick layer of spacer, this layer of spacer will be filled with composite material, and when you will light cure this composite material, it will shrink. And if there was no IDS and you do your bonding indenting, theoretically what may happen, it may cause some debonding from dentin because of the shrinkage of thick layer of cement that you are using. So in that case, you may get your postoperative sensitivity. Okay, so if you follow these rules, you may have super low numbers of postoperative sensitivity. Then, replying to your question, because sometimes you have, and you have to know what to do. So first, easy thing. We can keep our patient weight. We have to inform our patient before cementing that in some cases people may have postoperative sensitivity because it is individual property of some people, just to give us sort of excuse into the future. Okay, then we have to say there are different types of postoperative sensitivity. The one that is short lasting, just few days and it's gone by itself, perfect. Maybe it comes because you polish margins too heavy, maybe rubbing isolation was too aggressive, or whatever. It may disappear in short time. Then there is a long-lasting postoperative sensitivity, and it may disappear in sort of time. It depends on what? It depends on the time of vertical dentin development. According to some articles, the vertical dentin development goes roughly 3 weeks or 4 weeks. So basically your patient may be staying with postoperative sensitivity within 3-4 weeks. But when you have your patient with all this timing spent, 1 month later postoperative sensitivity, in this case I would remove restoration and I would redo this restoration, because if there is no pulpitis, if it is postoperative sensitivity caused by debonding. How do you determine if it is postoperative sensitivity caused of debonding in comparison with pulpitis? Symptoms. Okay, symptoms. So that is the thing. Wow, my friends, a lot of questions. Actually, it's good to have all of these questions, but unfortunately I don't have enough time to reply to all of your questions, because I also have to go. So I would like to thank you all for participating. I will do some live broadcasts on Instagram from time to time. I will promise you. Okay, but also we will do live broadcasts here, and we keep recording for people, so you can actually see that in record this dental talks. Okay, I invite you to participate our online masterclass. Since you cannot come to our hands-on courses, you can have a really high-end online education, our specific hands-on, online workshops. The link is below. I would like to wish you health. I would like to wish you positive mind, to have it clear, to have it with no stress, to love each other, to love your family, to stay time with family more, to read, and to have rest, because, for example, now you can sleep more, which is good, to gain power. And fortunately, all the situation around coronavirus will be overcome soon, and we can go back to our normal dental, and not only dental but social life as well. One more time, thank you very much. See you soon. Bye bye.